You're listening to BioTalk with Rich Bendis, the only podcast focused on the BioHealth Capital Region. Each episode, we'll talk to leaders in the industry to break down the biggest topics happening today in BioHealth.
Hi, this is Rich Bendis. I'm your host for BioTalk, and we really have two distinguished doctors that we're going to have on this episode today. And they're brought to us really by one of our board members at BioHealth Innovation, Donna Edmonds, who's the CEO of BrainBox in Virginia. These two doctors are involved with the research going on in the technology at BrainBox. And we're pleased to have Dr. Frank Peacock IV, Professor of Emergency Medicine and Vice Chair for Research at Baylor College of Medicine, and Dr. Damon Kuehl, who is the Associate Professor of Emergency Medicine and Vice Chair for Research at Virginia Tech Kuehl School of Medicine, on BioTalk with us today. So, gentlemen, welcome to BioTalk.
Thank you.
Thanks.
Generally, we introduce our guest, but rather than I doing that, no one could introduce you better than yourselves. We're going to let Frank start. Dr. Frank Peacock is going to give us a little bit of his background and why we should be interested in his affiliation with BrainBox and this great technology. Frank?
So I've been practicing emergency physician for about 40 years. I trained in Detroit, which is a pretty good place to start, and then moved to Cleveland, where I did cardiovascular research for 17 years. And in 2012, I moved on to Bentab, which is the county hospital for Houston, the third largest city in the United States. And suddenly my world was full of trauma like I'd never seen before. As a county hospital, you're the trauma center, and they would come in. It's not like I saw one a day. I saw one an hour. At that point, it becomes obvious we have a hole in our repertoire of caring for these people. And that's when BrainBox showed up and asked for me to help them with their trial, which is a diagnostic for traumatic brain injury. And we'll get into that a lot more later. I'm going to turn this over to Damon and let him brag about himself for a minute.
Great. Thank you, Frank. And we're talking about Dr. Damon Kuehl. Damon?
Well, I've only got 21 years of emergency medicine under my belt, so Frank, you got me beat. I have been with Virginia Tech and Kuehl for now almost 20 years, including my affiliation with Virginia Tech and the Center for Human Injury and the Helmet Lab. I trained at Stanford University in emergency medicine and then completed my research fellowship in Oregon. My work is really focused around diagnostic uncertainty, and a lot of work that I've done now is really dedicated to understanding mild traumatic brain injury. And I use that word because most people understand the word, but we really don't clinically. Mild can still be very severe. We know that day in and day out as we work through our patients in the emergency department, as Frank alluded to, that head trauma for me is an hourly occurrence that I manage, not a day or a weekly event.
Well, thank you for both joining, and both have similar backgrounds. And we know that we've heard a lot more about the traumatic brain injury. We hear it a lot, really, from a military perspective and a sports perspective, from what I hear. But why don't you walk through a typical scenario of a patient who comes into the emergency room after this sports industry or a suspected concussion? What happens from a diagnosis standpoint today? And really, what are the limitations related to that diagnostic? And I'll start with Dr. Peacock.
So you act like there is a diagnosis, and this is the biggest problem. And Damon alluded to that when a patient comes in and they got hit in the head, you'd hope there's a test. We have a test for heart attack, and we got a test for pneumonia, but the test for traumatic brain injury does not exist. And people are horrified. They say, no, you're just wrong. You're an idiot. It's like, no, there is not one. I can get a CAT scan. It shows if your brain is bleeding. Most of those are negative, by the way, 95%. We get CAT scans left and right. So the trouble is, if you got hit in the head, are you going to have symptoms or not? And I have no ability to predict that. So we don't have a diagnostic. It's the big unmet need. And besides that, we don't have a therapeutic. You come in and get pneumonia, I give you antibiotics. Well, you have a heart attack, I may work to get your blood recirculating your heart. You come in with traumatic brain injury, I got nothing. So I don't have a test and I don't have a treatment. We're pretty much out in the woods right now. And that's where both Damon and I are working to change the trajectory here so that we can get a treatment and we can get a diagnostic and we can help these patients who've gotten hit in the head.
So basically, what happens with the patient today in the current environment when they come in? Damon, maybe we'll go to you and ask, you can tell us what happens when they come in to the emergency room today with that type of a concussion.
Well, as Frank alluded to, the CT scan is almost always normal. Emergency physicians, even if they're the greatest neurologists in training, like my father-in-law is a neurologist, and I feel pretty confident about my neurologic exam, it still fails our ability to make a diagnosis. And commonly, patients come in with some symptoms, and our CT scan is reassuringly normal. And for all of my career, it has been the phrase, "the good news, ma'am, your head CT is normal." And that's probably the bad news, because the vast majority of those patients, clinicians are falsely reassured by that normal head CT. And so we're missing an enormous number of patients who will go on to have persistent symptoms, all because we've relied so heavily on what I like to call the donut of lies. Some people call it the donut of truth.
Okay. The last thing we really need is to be lied to when we go to the emergency room. So, what happens really to the patient when this concussion or brain injury is missed and it's not clearly diagnosed because we don't really have the tools today and there's an unmet need? What does it mean for that person who's being injured? And what happens to that patient next where there's been no diagnosis of what the real harm has been to that potential patient?
Well, the good news is Frank and I just published a paper on what happens to some of these patients who get missed.
And Frank, do you want to talk about what's in this paper rather than keep it in a mystery?
The patient's gotten hit in the head and showed up in the ER. Either the exam's normal, we send you home, or the CAT scan's normal, we send you home. The small percentage with the abnormal CAT scan generally will get stayed for a while. But so you're going home. And the question is, are you going to be functional and fine, or are you going to be miserable? About a third of these people go home and just normal. They got hit in the head, but they're fine. They go back to work and life's fine. But the danger, that other group, the challenge is if you've gotten one hit, you don't want to take a second hit. So if you're a cop, should I send you home? I call it the traumatic brain injury environment, because that second hit can be really harmful. So there is some danger for the patient, but there's also the symptoms that can be protracted. And the paper we're alluding to is we had tried to identify who showed up in the ER is going to be symptomatic in 30 days. Because if a month later you're still having symptoms, that's brutal. And the symptoms are they can't see right. They watch TV and they get nauseated and throw up, and they can't sleep right. And they have this persistent headache that won't go away. And you take everything we give for headaches, doesn't work. And these people are miserable. And it's no surprise they get very short-tempered and they yell at their boss. They get fired. They beat their wife. It's a downhill stream for them. It's really bad. And we have no way of knowing who's going to fall into that category versus those who are going to be fine. And we did a study. Emergency docs can identify, if I say you're going to be negative, the probability of me being correct is 8%. It's not a typo, 8%.
8%.
So 92% of the time we're wrong when we say you're going to be negative. This is why we so desperately need new tools.
Was this part of do you call that the HeadSMART II study?
That's where we suck the data out of. We've got a couple thousand patients, and I don't know if you want me to get into the details right now, but we've got a big database of prospectively gathered patients who have been studied really quite extensively with the intent of identifying blood tests and neuropsychiatric testing that will diagnose that patient as well as predict who's going to be symptomatic down the road.
When did this paper come out, by the way?
So there's a series of them. The one on the predicting symptoms at 30 days came out last year.
So I'm sure before we're done, we can let the listeners who are interested in that paper, we can tell them where they can find it. Where has it been published?
JAMA Open Neurology. So they can go on the internet and pull it down right now. It's free.
I haven't read the paper, and I'm sure most of the listeners here have not. What was the conclusion that you both came to when you published this paper?
We were looking for predictors of who would be symptomatic in 30 days. And what they came out to be was if you were female, you're more likely to be prolonged symptoms. If you have had headaches in the past, you're more likely to have them again. If you presented with a headache, that's problematic. And then if you have some history of psychiatric dysfunction, you had anxiety or depression issues, you're more likely to have persistent symptoms. And if the doctor got more than one CAT scan, and when that happens, that means you come in, you get a CAT scan, the patient lays around the ER, next day they get hospitalized. 2 days later, they're not right. We better get another CAT scan, make sure they don't have a bleed. If you're one of those people, then you're more likely to have persistent symptoms. The issue is, what are we going to do about that? If I can tell you're going to have symptoms, well, the first thing I'm going to do is I'm going to enroll you in my therapy trial and see if we can prevent you from having persistent symptoms. But the other thing is that there are some interventions that have benefit if they're started early. And if you delay, that benefit sort of goes away. And they're simple. They're occupational therapy type of stuff. And there's vision. So people have trouble with their vision. I say go into vision school. They train you to make your eyes move together. If you have balance inequity, so you're about to fall down all the time, that's really disconcerting. You train those people, they do much better. If you wait a month, they don't do much better. So if you can identify who's going to be symptomatic early, we do have some interventions. They're not like a pill and you're cured, but they are definitely change the trajectory of that patient's future.
Damon, anything you'd like to add to that?
The major piece of all of this is if you want to do and develop a drug or a therapeutic intervention real time as fast as possible, right now, if you have an 8% rate of getting it correct of who's going to have persistent symptoms, you don't know who to enroll in the trial. That's why Frank brought up the first thing I would do is enroll those people, because those are the ones where that therapeutic event matters the most.
The most juice for your squeeze.
Okay, the most juice for your squeeze. How about that? You guys both have a lot of colloquialisms that we can add to the medical profession these days. Tell me a little bit about when you look at the components to what you're talking about around this diagnostic test or the therapeutic. What are the critical elements that are involved there? And I know that you're both here because Donna Edmonds from BrainBox suggested that we have this BioTalk podcast to talk about this challenge where there's this tremendous unmet need. Tell me a little bit about how you both got involved with BrainBox and what is their role in coming up with a solution to this challenge we have.
Well, I think Frank already commented about how he was approached by Donna. I was similar. I had been working with the Department of Defense on a couple of studies looking at our human imaging center with MRI of blast injuries and brain injury. We were able to turn a couple of those trials into some of the work that for HeadSMART II, as well as my work that I'm doing with HeadSMART Geriatrics and older adults with brain injury. Coming into this, the real understanding and why you had me at hello was because it can't just be a couple of blood tests. We already have learned the shortfall of a few biomarkers that are out there to predict whether a CT is positive or negative. It doesn't matter. The real outcome that we're interested in is, do you have a brain injury or not? And with that, you have to be able to do an objective test of some kind that I am not fast enough to do, that includes balance, coordination, and eye tracking and memory. That is the crux of what we need as a test, especially at the point of care in emergency medicine, is a combination of objective physiologic testing and biologic testing. And that's why I'm so excited about what we're doing.
That's the thing about the HeadSMART program, and Damon's in charge of the geriatric side of that, is that we are testing a group of tests. It's blood and it's neuropsychiatric. And Damon mentioned the balance, the vision, all that. And the reason to do that is, if you can imagine, you get some guy who gets hammered on the football field and you drag him to the side of the field and you draw his blood, it's going to be absolutely normal. There is no blood test that's positive in a couple minutes. But his neuropsychiatric testing will be a mess. He'll be blurred vision, his memory will be off, and he doesn't know where he is. Well, that's a positive. And if they show up in the ER 3 hours later, their blood tests will be positive. One of the challenges we have in the emergency department is that half my traumatic brain injury patients are intoxicated on some kind of drug, either alcohol or whatever the drug of the day is. And if you do neuropsychiatric testing on them, it's a mess. You're a drunk fool. You can't do a test, but your blood test will be positive. And so each one of these parameters, they're sort of columns in the diagnosis, provides information that the other one doesn't. And together they are stronger than either by themselves. And you get an old person who's a little bit demented, and they show up after falling down, hit their head. You draw their blood. There may be some elevation in some of these tests because dementia creates some of these blood tests to be positive. And their neuropsychiatric dysfunction may be a little higher than normal because they are abnormal. This is where the AI part comes in there, is to do analyses to find out congruence. And this then allows us to do way more than a single test can do. And so that's the difference of the HeadSMART stuff, is it's a composite of several different tests combined into one answer.
What I've been reading about BrainBox is that, in my non-professional way, saying they're developing a multi-modal test that uses AI algorithms. And AI is a mysterious technology out there that we're all afraid about what it's going to do, but there are also some significant benefits from what AI can do. And talk a little bit about the integration of data from the blood markers, the neurocognitive assessments, the clinical information, and how you're trying to come up with some type of a scoring mechanism that helps you do a better diagnosis with these patients. So I don't know if it's Damon or Frank that wants to take a lead on that. Damon, it looks like you're shaking your head. You want to take a lead on that?
I'm not shaking my head. I'm agreeing with all of the pieces that you just sort of mentioned, is because while heart attacks are complex and they're no good for any patient, brain injury is more complex. You're bringing in things like alcohol consumption or drug use or age and anxiety and depression that happened before you got in the car crash. There are so many pieces that go into it that one or two single blood tests is not going to be the answer, or some amazing physical exam finding. So combining all of those does require a level of sophistication that is worthy of the complexity of the brain. We just published a paper showing that a battery of tests that we collect on older adults, and Frank was on this as well, that takes hours to deliver to figure out if they have some cognitive impairment or they might have a concussion, can be done with a little AI and software and an iPad just as good in a few minutes. Leveraging reaction times and balance and coordination with the blood and their biology with symptoms all in combination is the only way we're going to get very accurate at this.
The science is only as good as the data going in. This has been the challenge historically. And the advantage of the HeadSMART II trial is that we have 2,000 prospectively enrolled patients in who we have collected data. And we've done it when they show up in the ER 14 days, at 30 days, and at 90 days. So we're getting physiologic measurements, and they're doing neuropsychiatric tests at the same time. And in parallel, we're collecting data on people who just broke their leg and didn't smack their head, and people who didn't do anything, they're just walking down the street. But the advantage of that is when you're talking about powering your AI tool, it's got to have something to measure against. And this is where the value of this comes in, is at 2,000 patients, you're pretty much got enough information that the smallest group of people will still be able to be discerned because of the quality and quantity of the data. I mean, that's the important thing about that trial.
I think that's extremely important. If I'm a clinician and you're talking about trying to get to real-time data, tell us a little bit about how a diagnostic test would be administered and how much time would there be from the time the test would be administered to the time that the clinician has real-time data to make decision on that.
So that depends on how you run your blood test. I can send it to my lab, it takes 90 minutes, or I can do it on a point of care. And our preference has been to be the point of care. So there's a test next to me in the ER, and that takes 7 or 8 minutes usually. The neuropsychiatric side of that is you hand the patient an iPad, and they'll be done in 5 minutes. It's really simple. It's like playing video games. You don't even have to give them instructions. You just say, do this. And they look and go, oh, you mean the arrow says to push over here? And so the answer to your question is it's maybe 15 minutes and we'll have an answer.
And right now you're saying nothing exists to give anything close to real-time data to the emergency room physician to be able to assess where that patient is at this point.
Correct. When you're in the ER, if you come in with a heart attack, I can do some tests, and I know that in 30 days, you're going to be either dead or surviving a heart attack, but you won't be the same you that came in the door. When you come in after a head injury, I don't have a clue what the next 30 days is going to look like for you. If you have a negative CAT scan, our answer is, you might have a headache, take some Tylenol and go home. That's not a great answer because you could be miserable in 30 days. We have all these risk scores that are essentially a measure of how miserable you are. It's not a good thing.
Damon, do you want to elaborate on that?
Just to add to that, it's not just head injury or head trauma. We have a tremendous number of people who do not know if they've had head trauma. Those are the worst, right? I was in a car crash. It would happen so fast.
I hear that all the time.
It's an enormous population that we see every day. It's one thing to be luxurious and say the patient hit their head, it was witnessed on the soccer field, and they lost consciousness and they were out for 15 minutes. We never get that luxury, especially in older adults. In the work that I do in falls and brain injury, 90% of all of the falls of the patients I enroll are unwitnessed, and they have no idea what happened because they may have some cognitive impairment or they just rolled out of bed when they were sleeping. This is absolutely necessary for us to push this to get it in the hands of clinicians.
So, Frank, you mentioned 30 days several times when we just chatted there a second. So, is the goal here is trying to identify patients who are the most likely to have persistent 30-day symptoms after the accident occurred, and that's what this test is being created to do?
So 30 days is somewhat arbitrary. And the reason that number is used is because if you're better in 2 weeks, do I really need to give you an intervention that might have a risk? And every intervention has risk. I even give you a glass of milk, there's a risk associated with that. If you're better in 2 weeks, you probably don't need any intervention. The answer is just go home, have a headache. You'll be better in 2 weeks, go back to work. But if you're going to be symptomatic at 30 days, it's pretty much declared itself as being persistent. The reason we pick 30 days is because if you come back and get hospitalized, insurance company don't pay for the pre-30-day readmission. That's sort of the standard in medicine is 30 days is magic. It's not really magic at all. But if you're symptomatic longer than that, it's clearly persistent. And most people who'd had a 30-day headache would take the risk of a treatment at that point.
So you've had your 2,000 patient study. Where are we now? Because as you're looking at clinical trials for things like this test, sometimes it takes a long period of time before you can actually see it actually get into the marketplace. So where do you believe you are with the BrainBox technology right now? The studies that have been done, the papers that have been written, what are the next steps? And when would we likely be able to see something actually enter the marketplace?
The plan is to get FDA clearance, and we are putting that together while we're talking right now. And then it's going to be in the hands of the FDA. We have a series of markers that if they are positive, they are predictive of bad outcomes, 30-day persistent symptoms, et cetera. And we have the neurocognitive testing to pair it up. If the FDA is on board, there's like a 180-day cycle there. We could be out there pretty quickly. If the FDA has concerns and questions, then we have to deal with that. So there's a bit of a predicting the future there. But best case scenario, we're not a long way off.
That's pretty encouraging. What do you see as the next major milestone that needs to be achieved in the progress for this test?
The FDA.
The FDA.
Your federal government.
Our federal government, not my federal government, it's our federal government. This has been a really good tutorial on where we stand with a potential technology to meet an unmet need, especially something that impacts so many people. We've been speaking with Dr. Frank Peacock, who's the professor of emergency medicine and vice chair for research at Baylor College of Medicine, and Dr. Damon Kuehl, who is the associate professor for emergency medicine and vice chair for research at Virginia Tech Kuehl School of Medicine. Before we close, what is it that we should have talked about to educate our listeners anymore above and beyond what both of you have said? And I'll start with you, Frank.
Well, I think once we have a diagnostic, the next obvious part of this is going to be get a therapeutic. We have a number of those in the pipeline. As Damon alluded to, the challenge is testing these patients because we can't predict who's going to be sick or not. Once we have a test and can predict that, all of a sudden, the speed of which we can develop new drugs is going to quadruple. It'll be much faster than what we've been sort of running in circles in the last 20 years.
Is the work on the therapeutic underway in parallel with the diagnostics?
Yes.
Definitely at a different stage and going to require much more FDA regulatory oversight than the diagnostic will.
Yeah, add 5 years.
Okay, great. So the sooner the better on the diagnostic. Damon, anything from your end that we didn't cover that you'd like to leave with our listeners?
Two things. One is I still have conversations with physicians about why this is needed. We spent a very long time in emergency medicine and the entire field of trauma focusing that a CT scan imaging was the answer to tell the neurosurgeon what to do. But it told none of our patients what was going to happen to them when it was normal or our clinicians. And I still have to explain that to really smart people. Number two is I think it'll go faster and faster. We have been dragging our feet a little bit to get this technology right and do it correctly. I think there's a lot of science right now that is coming out, but it falls short because people are so focused on a single lab test or just one magic bullet. And instead, it really does have to be a complex, well-developed multimodal test to really give us the answers that patients and clinicians deserve to have in their hands.
Thank you very much. I really want to appreciate Donna Edmonds for introducing us to both of you, as we really like to support the companies in our BioHealth Capital region, because this is not an easy journey that she has been on with this company and with this technology. And it takes experts like both of you to help support the entrepreneurs in these companies as they are trying to grow. So hopefully, once you get the FDA approval, I'd like to come back and talk to you about that success. And then let's talk about the pathway for the therapeutic. But I appreciate Dr. Frank Peacock and Dr. Damon Kuehl for both being on BioTalk today. And thank Donna Edmonds for introducing us to both of you. So thank you very much.
Thank you.
Thanks for having me.
Thanks for listening to BioTalk with Rich Bendis.